If you want to reverse cellular aging in the most sensitive, fragile tissues of the human body, the answer actually isn't a new synthetic chemical.
Right. It's really
They're
not.
highly purified DNA fragments harvested from salmon sperm, which is wild. And to successfully deliver that biological payload, doctors are having to completely rewrite the rules of injection protocols, literally mapping out human tissue millimeter by microscopic millimeter.
Yeah, it's a massive shift in how we approach this.
Welcome to the deep dive. Today we are looking at the rapidly advancing field of aesthetic and regenerative gynecology, and we are specifically focusing on polynucleotide therapies.
Which is such a fascinating area right now.
Totally. And we are pulling from a heavy stack of clinical data today, including the 2025 Maturitas randomized controlled trial, alongside these highly specialized aesthetic protocols from Mastelli and Dr. Fasola.
Really rigorous stuff.
Yeah. And the mission for this deep dive is to explore exactly how medical professionals are forced to radically adapt their techniques when depositing these regenerative molecules into two, vastly different landscapes.
Right, because you have the relatively robust outer labia majora skin folds, and then
And then the incredibly delicate internal vaginal mucosa. It's night and day.
the contrast in those two approaches really tells you everything you need to know about the complexity of intimate anatomy. You are dealing with two completely different structural environments,
Right.
and they require completely different physical tools, totally different volumes, and different depths to actually achieve tissue regeneration.
And whether you're a medical professional or just someone curious about longevity and tissue repair, or, just a learner fascinated by microscopic precision, this deep dive is going to completely change how you view tissue repair.
I really think it will.
But before we can get into the how, we kind of need to understand the what.
Yeah,
Because this gel acts as a biological instruction manual.
exactly.
Okay, let's unpack this. We're talking about polynucleotides,
Yeah.
specifically PNHPT, and these are not, your standard inert dermal fillers.
No, not at all. When you look at traditional cross-linked hyaluronic acid, you are essentially dealing with a space-occupying lesion.
Right, it just sits there.
Yeah, it just sits in the tissue, it holds water, and it provides mechanical volume until it eventually degrades. But polynucleotides operate on an entirely different biological axis.
Because they're active biological communicators, right?
Yes, they are active biological communicators, and the manufacturing process for PNHPT is actually brutal by design.
Oh, wow. What do you mean?
Well, they extract the DNA from salmon or trout, and then they subject it to extreme high-temperature sterilization and deproteinization.
That's intense.
It is, but that aggressive purification is critical because it strips away all the immunogenic proteins, leaving behind just the pure biologically active nucleic acid polymers.
And the reason this matters for the patient is that it bypasses the immune system's rejection response, right? It allows these foreign DNA fragments to seamlessly interact with human cellular receptors.
Exactly. The sources detail how these fragments specifically target and bind to CD44 receptors on human cells.
So this isn't just about adding volume. This is about triggering the salvage pathway.
That's the key. The local cells, particularly the fibroblasts, recognize these polynucleotides, they break them down, and utilize the raw nucleotides to synthesize new RNA and DNA.
It's like forcing the cell to increase its metabolic rate.
Right.
And just ramp up production of type 1 and type 3 collagen.
Yeah, and you also see a profound modulation of the inflammatory cascade. The polynucleotides act as scavengers for free hydroxyl radicals.
Oh, that's interesting.
So while they are upregulating collagen and extracellular matrix protein synthesis, they are simultaneously clearing out oxidative stress in the local microenvironment.
And in the specific clinical formulations we are examining today, like the NutriStrobacol, these polynucleotides are deployed in a very specific triad.
Right, they aren't just used alone.
Yeah, they are combined with uncross-linked hyaluronic acid and mannitol. And that triad formulation solves a major problem in regenerative medicine.
It really does. Uncross-linked hyaluronic acid is highly fluid, and it integrates beautifully into tissue to provide immediate hydration.
But the human body's natural hyaluronidase enzymes will break it down almost immediately, right?
Exactly. And that is where the mannitol comes into play. It's a polyol, a type of sugar alcohol, and it physically acts as an antioxidant shield.
So it quenches the reactive oxygen species that would normally cleave the hyaluronic acid polymer chains, which drastically slows down that degradation process.
It basically creates a temporal window.
I like to think of this whole formulation like a construction site.
Oh,
So
Okay.
the hyaluronic acid is kind of like bringing in emergency water to a totally dried out sponge,
Right.
while the polynucleotides are the foremen, basically hiring new workers to permanently rebuild the sponge's structural scaffolding.
That is a great way to visualize it. The uncross-linked HA provides the immediate physical hydration required by dehydrated atrophic tissue.
And the mannitol protects it.
Yeah, the mannitol protects that hydration layer, giving the polynucleotides the weeks and months they actually need to biologically reprogram the fibroblasts to rebuild that permanent structural matrix.
But to understand why that structural matrix needs rebuilding in the first place, we really have to look at the baseline state of the tissue we are treating here.
Which is usually severely compromised.
Yeah. We are primarily looking at genitourinary syndrome of menopause, GSM, and specifically vulvovaginal atrophy, or VVA.
When local estrogen levels crash, the histological changes to the mucosa are just severe.
The clinical descriptions note that the tissue becomes visibly pale due to decreased vascularity. The collagen fibers literally fuse together,
No.
and the elastic fibers become highly fragmented. The epithelial layer thins out to just a fraction of its normal depth.
So for patients dealing with the severe dyspareunia, the painful intercourse, and the microfissuring that accompanies VVA, the mucosal barrier has essentially just failed. It's a total functional collapse. The goal of this treatment isn't just cosmetic. It's a functional restoration to treat that dryness, the itching, and the pain.
Right. That structural reality dictates the entire clinical approach because this gel is fundamentally altering the tissue architecture. Placing it requires immense precision.
Absolutely.
Here's where it gets really interesting. Let's look at the thicker outer tissue first. The labia majora acts functionally more like traditional skin.
Yeah, you have a stratified squamous epithelium, a distinct dermis, a subcutaneous fat layer, and dartos fascia.
And when this area degrades due to age or estrogen loss, it mostly presents as significant volume loss and amentosis, or, sagging.
Right. The clinical protocols for the labia majora reflect that robust architecture. According to the Mastelli and Dr. Fasola guidelines, practitioners are utilizing a 30 to 32 gauge needle.
And the needle length is 13 millimeters, right?
Yes, and they are inserting this at a fairly steep 30 to 45-degree angle to completely bypass the epidermis and dermis.
So they're targeting the superficial subcutaneous plane where that structural scaffolding has collapsed.
Exactly. The 13-millimeter needle allows the practitioner to execute these broad, sweeping delivery methods. The gold standard here is the subcutaneous fan technique.
Often combined with a linear retrograde pattern, according to the sources.
Right. The physician anchors the needle at a single entry point, they advance it fully into the subcutaneous space, and they deposit a thread of the viscoelastic gel as they slowly withdraw.
And then before exiting the skin, they pivot the needle a few degrees, advance it again, and lay down another thread.
Creating a wide, fan-like distribution of the product across the tissue plane.
Okay, but I'm having a hard time visualizing the fluid dynamics of this specific step.
How so?
Well, the protocols call for 0.3 milliliters per point, totaling up to 0.9 milliliters per injection site.
Right.
And they are potentially pushing 1.5 to 3.0 milliliters of this gel per side of the labia.
Yeah, it's a relatively large volume.
If we are injecting up to 3 ml of this gel into the outer folds using a fan technique, how do doctors avoid it looking unnatural or lumpy? I mean, is this just like plumping up lips on a face?
What's fascinating here is that it's about structural support, not just plumping. The thicker tissue of the labia has lost volume and is sagging due to age or weight loss.
Right, a macrostructural issue.
Exactly. The tissue compliance of the dartos fascia and the subcutaneous fat pads in the labia majora is remarkably high, meaning it can accommodate larger volumes if distributed correctly.
But there's still a risk, right?
Oh, definitely. Your concern about unnatural deformation is exactly what the top clinicians warn against. Doctors must strictly avoid overcorrection.
Because if a practitioner approaches it with the same aggressive, volumizing mindset they might use on a jawline.
The results are aesthetically and functionally disastrous. It can lead to an unnatural appearance that is sometimes referred to in the literature as a testicular appearance.
Yikes. So how do they actually smooth it out then?
A mandatory part of the protocol is a prolonged, vigorous post-injection massage.
Really? Just manually massaging it?
Yeah, the physician must manually knead the outer tissue folds to force that viscoelastic gel to spread evenly through the subcutaneous septa.
So that prevents the pooling or asymmetric nodule formation. You're treating the tissue like a foundation that needs broad, even support.
Exactly.
But you can probably imagine the disaster if a doctor tried to use that same 13-millimeter needle and fanning technique on the fragile inner mucosa.
Oh, it would be catastrophic.
The moment we cross the heart's line and transition from the outer folds to the vaginal mucosa and the vestibule, the clinical protocols completely flip.
The anatomical landscape changes instantaneously. You lose the thick keratinized layer, you lose the subcutaneous fat pads, and you are left with a highly vulnerable, non-keratinized epithelium.
Which is overlying a very, very thin lamina propria. And the equipment shift is just drastic. That 13-millimeter needle is immediately discarded.
Right, for the internal mucosa, practitioners switch to an ultra-short 4-millimeter needle.
And they aren't even using the full 4 millimeters. The depth of the injection becomes genuinely microscopic.
It really does. The protocols specify depths of just 1 to 1.5 millimeters for the anterior vaginal wall.
And 1 to 2 millimeters for the posterior wall.
Yes, and an incredibly shallow 0.5 to 1 millimeter for the vestibule.
The margins for error at those depths are practically non-existent.
They really are. And if we connect this to the bigger picture, the reason the depth is so rigorously controlled comes down to the vascular architecture of the vaginal walls.
Right, because just beneath that incredibly thin mucosal surface lies a dense network of submucosal venous plexuses.
Exactly. If you penetrate too deeply into that vascular bed,
You trigger severe hemorrhaging, right?
yeah, and massive hematoma formation within tissue that is already chronically inflamed and highly sensitive.
So by restricting the penetration to 1 or 2 millimeters, the practitioner ensures the polynucleotides are delivered exactly where the fibroblasts live without hitting those dense venous plexuses.
Or causing severe trauma to the already friable tissue, yeah. You avoid the deeper muscularis layer with the regenerative signaling would just be wasted.
And the delivery pattern is just as meticulous. The sweeping fan techniques are abandoned entirely.
Completely.
Instead, the physician maps out the vaginal walls into geometric segments, and they utilize microbolus injections or microwheels.
Basically, tiny hives of the gel.
Yeah, and we are talking about tiny drops, volumes as small as 0.03 to 0.1 milliliters per point.
And they space these microscopic drops 0.5 to 1 centimeter apart, moving systematically up to 2 centimeters deep into the vaginal canal.
It's just a totally different mindset. I mean, the labia protocol is kind of like painting a sturdy exterior wall with a broad roller.
Right.
Whereas the mucosal protocol is like using a fine-tipped brush to apply tiny dots of restorative paint to a super fragile antique silk canvas.
That's a perfect analogy, and it requires an immense level of focus from the physician. The adaptation for the vestibule is particularly critical.
Because neurologically, it has the vastly higher density of nociceptors, right?
Exactly. Pain receptors. It has way more than the deeper vaginal walls.
Which explains the strict 0.5 millimeter depth limit for the vestibule. You are essentially skimming the very surface of the tissue.
If you deposit even a fraction of a milliliter too deeply in the vestibule, or if you deposit too large of a bolus, the fluid pressure alone will compress those nerve endings,
Causing acute, agonizing pain for the patient.
Yeah. The 0.03 milliliter microwheel ensures you don't overwhelm the friable tissue with fluid volume while still delivering enough polynucleotides to trigger the localized fibroblast activation.
So what does this all mean? Looking at the sheer mechanical repetition of this protocol, placing dozens upon dozens of microscopic drops exactly 1 centimeter apart at highly specific depths, it seems like a logistical nightmare for a human being to execute consistently.
It is definitely technically demanding.
Right, and we have automated mesotherapy guns and machine skin boosters equipped with multi-needle arrays that can stamp a programmed volume of product at a uniform depth across a wide area.
We do, yeah.
So why are clinicians manually hand-injecting these microboluses when a machine could theoretically do it faster and with perfect mathematical consistency?
Well, the clinical consensus for this specific therapy strongly favors the human hand. The limitation of the machine in this specific anatomical context is its inability to process what the literature refers to as decision frequency.
Decision frequency.
Yeah, an automated mesotherapy gun is highly efficient on a broad, flat, relatively uniform plane of tissue, but the vaginal canal and the vestibule represent incredibly complex variable topography.
Because intimate anatomy isn't flat or uniform. You are dealing with highly individualized anatomical folds and rugae.
And beyond just the natural folds, you are constantly encountering localized tissue anomalies.
Like what?
Well, a postmenopausal patient may have dense fibrotic scar tissue from an episiotomy performed decades prior, or localized areas of severe mucosal thinning right next to relatively healthy tissue.
Oh, I see. So if an automated multi-needle device stamps that area at a programmed 1.5 millimeter depth, it might deliver perfectly to the healthy mucosa.
But it will simultaneously drive needles far too deeply into the thinned areas, or completely fail to penetrate the dense fibrotic scar tissue effectively.
Because the machine lacks tactile feedback. It can't feel the tissue pushing back.
Exactly.
Yeah.
The human hand can adjust pressure, angle, and depth millimeter by millimeter in real time. The physician can sense the increased resistance of a fibrotic band and instantly adjust the pressure on the plunger.
Or change the angle of the needle by a few degrees to navigate around a venous plexus.
Right. They can read the immediate somatic responses of the patient when navigating the hypersensitive vestibule and micro-adjust the depth from 1 millimeter to 0.5 millimeters instantly.
And the data supports this manual approach overwhelmingly.
Yes, it really does.
When you look at the methodology of the 2025 Mituitis Multicenter Randomized Controlled Trial, they utilized hand-injected techniques for the mucosal delivery.
And the clinical endpoints they measured were rigorous. They didn't just ask patients if they felt better.
Right. They measured the vaginal health index. They tracked objective increases in mucosal elasticity and fluid volume. And they recorded significant measurable reductions in dyspareunia.
The Majora study represents gold standard evidence that this highly customized tactile delivery method is not only safe, but profoundly efficacious.
Which is amazing.
But this raises an important question, for you, the listener, to consider. How do we balance the desire for automated, fast medical technology with the undeniable necessity of customized human tactile feedback in highly sensitive procedures?
It's a fascinating juxtaposition. We are utilizing one of the most advanced biological payloads in regenerative medicine, right?
Yeah.
Purified DNA fragments designed to reverse tissue atrophy. But the success of that payload relies entirely on the ancient analog sensitivity of the human hand.
It perfectly illustrates why aesthetic and regenerative gynecology requires such highly specialized training.
So to pull all of this together, because the sheer scale of the adaptation we've covered is incredible. When clinicians are targeting the outer labia majora, they use 13 millimeter needles to bypass the dermis entirely.
Utilizing those broad, sweeping, subcutaneous fan techniques.
Right, laying down relatively massive volumes of up to 3 milliliters per side to restore the subcutaneous scaffolding, and relying on vigorous manual massage to prevent unnatural contours.
Yeah, they are basically reinforcing a failing macroscopic architecture.
But the second they cross into the inner mucosa to treat the severe histological realities of vulvovaginal atrophy, the entire paradigm shrinks.
Completely shrinks.
They swap to ultra-shallow 4 millimeter needles, restricting their depth to an incredibly precise 0.5 to 2 millimeter window to rescue the fragile, estrogen-depleted inner mucosa without triggering massive hematomas.
They abandon the fan technique entirely in favor of hand-injecting dozens of microscopic 0.03 milliliter microdroplets.
Reading the tactile resistance of the tissue to drop the polynucleotides exactly where the fibroblasts can utilize them.
It is a masterclass in respecting local anatomy.
It really is. This isn't just about aesthetics. It's about utilizing biological blueprints to non-surgically and non-hormonally restore a woman's quality of life, comfort, and sexual health.
That's the real takeaway here, directly treating the chronic pain and degradation that millions of postmenopausal women experience.
And it completely shifts how we view the finality of tissue degradation, which leaves a rather staggering implication to consider as you step away from this deep dive.
Yeah.
If we have now refined the injection protocols to the point where we can safely deliver highly purified salmon DNA to the most fragile, estrogen-depleted mucosal tissue in the human body and literally command that specific millimeter of tissue to reverse its own atrophy and rebuild its own structural scaffolding.
It makes you wonder.
Right. What other unfixable or inevitable tissue degradation in the human body might this technology be able to reverse next? Are we actually looking at the end of localized aging? It's something to think about. See you next time.